Well, hello, everyone. Welcome to the second in a series of webinars regarding the future of hypertension care by Biobeat. My name is Jay Heimsoth, the National Director of Sales for Biobeat. Today's webinar is the clinical validation of a cuffless blood pressure monitor. We are joined by Dr. Elias Hellou. He's an interventional cardiologist from Medical Center in Israel and also a research collaborator from Mayo Clinic in Rochester. Dr. Hellou is going to review a lot of the validation information and evidence that we have on some new technology for managing and monitoring blood pressure. His work has bridged international cardiology and innovative device research, aiming to improve hypertension management and cardiovascular outcomes through real-world data and next-generation monitoring platforms. Dr. Hellou, I give it to you.
Thank you, Jay, and thank you everyone who's joining us today in this nice and easy presentation. And I think that I have two easy missions. One easy mission is to convince you that hypertension is a real problem and that we are facing a big challenge in the simplest thing in medicine, just to diagnose the hypertensive state of the patient or the normotensive state of the patient. And then I think that we have a nice way to do that. And this is also an easy mission for me with the good data that we already have. So thank you for joining us. And I don't want to make it any longer. I think that we all know that hypertension is very common. And for that simple problem, we can still see that 1 in 4 patients has uncontrolled hypertension. It's so frustrating for us as physicians. We know that in order to diagnose and to treat hypertension correctly, we need to diagnose it, and we know that we need to measure it. And we know that the current means of measuring the blood pressure is not very practical. And we see that the guidelines is pushing towards multiple readings or multiple blood pressure testing, which means that the patient should keep on testing his own blood pressure, or we should arrange an ABPM monitor for him. And we know that it's not accessible for all the people. We know that only 10% of patients has access to 24 hours ABPM, and this is a really significant gap in care. So what should we do? How can we overcome this problem? We do also know that even if we can't tackle the problem of technically performing the blood pressure monitoring, we know that cuff inflation by itself, the cuff that we can put on our arms, and when it inflates, it's not very innocent. Usually it would change the blood pressure. It has some, I could say, discomfort for patients. And usually when the patients are getting frequent measurements, they will just rip it off and throw it away. And mainly, many people do not complete the ABPM, which is the simplest and the most important way for us to diagnose and to measure and to quantify the blood pressure for them, thus choosing therapy. We know that the guidelines, as I said, are pushing more and more towards ABPM, and we see the gap in the will of the guidelines to do something and to diagnose accurately the blood pressure, especially at night period, and the gap or the hurdle of the patients for not being able to do that. I don't want to take any longer and to try to convince you that ABPM is a big operation. It's so simple, but in order to get that thing on the arm, patients should get an appointment. They should attend to the office, get the device, get it connected, keep it on, and return it back to the hospital or to the facility next day or next 2 days. Then there should be some reading to the people should kind of confirm the readings. This is not, we are not aware for that, but it's very important, and I'll show you some readings that are not very accurate when we get the ABPM monitoring. And then the device should be prepared for the next patient and consider all the difficulties in doing all of those. We now understand the limitation of ABPM. We already know from Lancet publication back in 1990 that there is an overestimation of blood pressure from the cuff. And even from 1990, with all the advancement that we have in the technology, mainly, most of the people did not overcome this step. And we can show you how maybe we can. We also know from many studies, and mainly one of the real-life meta-analysis who was conducted on 65 studies over 40,000 patients. We know that there is no total agreement between different types of measurements or different modalities that we use to measure blood pressure, which is so weird for us. We still think that the blood pressure is a gold standard, but how do we determine that gold standard? And apparently, when we do the different ways of determining the blood pressure, we can see up to 20 millimeters of mercury difference. I'm not considering yet the difference between the right arm and the left arm. I'm just talking about the same arm with different modalities. I think that those numbers, the 20% or the 20 millimeters of mercury, which could be as 20% difference, is a tremendous gap for us in order to diagnose correctly the blood pressure averages. I can tell you another thing, that we mainly cannot or will never be able to have an insight on the nighttime blood pressure as long as we don't use ABPM, no matter of the modalities now. I'm just talking about the modality of ABPM, because otherwise we don't know what's happening at night, and we cannot arise the patient and ask him to get his blood pressure measured. And we know from the literature, about the mortality from blood pressure, that it's not linear. The mortality of blood pressure mainly arises from the nighttime blood pressure or elevation. So whenever we do not use the ABPM monitoring, and whenever we rely only on awake measurements, we can never accurately assess the lifetime morbidity and mortality. And this is very important thing that we have to push towards going to ABPM diagnosis on blood pressure, even when the patient looks like he is controlled or okay. So we kind of have to make sure that the patient has the correct blood pressure measurements all the time, even when apparently things are looking good. I just want to tell you that you can ask your questions in the chat, and after the short presentation, we will answer your questions. Another hurdle that we do have is that usually when we rely on non-ABPM modalities, there are 1/3 of misdiagnosis. Misdiagnosis could be overdiagnosis of blood pressure, what we call masked hypertension, or white coat hypertension. So when considering those two problems, we can still find ourselves with 35% of misdiagnosis. Actually, I don't know anything in medicine that can accept 35% of misdiagnosis. You have here all the references that I'm relying on, so you can check me. Another important thing that I wanted to tell you, usually whenever we give a medication, when we prescribe for a patient, when we wish for a change or a decrease in blood pressure, usually every medication will do around 10 or 5 or 15 when we are very optimistic and the patient is very responsive, decrease of the systolic blood pressure. And there are so many reports in the literature saying that around 19% or 20% of patients, whenever the inflation happens, they raise their blood pressure by 11 to 20 millimeters of mercury. So how can we accurately assess not only the status of the patients, but our effect or the medication effect? I think that I rest my point, and now you know that probably we are not doing very good. So Biobeat has advanced the technology towards FDA clearance and validation for cuffless blood pressure monitor. And whenever we say cuffless, it's not understatement. It's over, and it's a very important thing. It's a very important progression to the way we perceive hypertension. I will convince you later on, but I want to take you through the validation process that Biobeat did in assessing and validating the accuracy and the usability of the blood pressure. At first, as we all do in our clinics, and the nurse would take the blood pressure in the arm and the wrist. Biobeat got 1,000 patients, and they assessed their blood pressure in a spot measure. And there was a level of acceptance of less than 0.1 bias, which means that in average, it was very convincing and it was very accurate. I can tell you that this was the first step, but it wasn't all. Biobeat also took one step further, and there was a validation process with arterial line where patients were selected in the intensive care unit, and during their stay in the intensive care unit, wherever they had the arterial line, which is the invasive way of measuring the blood pressure. And I think that for me as an invasive cardiologist, I could rely on that best. They also got their blood pressure in the non-invasive measures. But whenever you have the intra-arterial line, you can take the blood pressure instantaneously and continuously. And also Biobeat can give that data for us. So there was an amazing level of acceptance also on that. But for us, who cares about the arterial line whenever we should treat our patients in the ambulatory settings? So Biobeat also took an advancement in the ambulatory settings, and maybe this is the modality that we will use most, as we can get the Biobeat patch and get a measurement every 15 minutes. And during the entire day, we will get 97 measures. So let me show you, we remember this study because we will have a deep dive into this study later on. But already on 2021, 28 patients were connected simultaneously or in parallel to the classical ABPM monitoring and to Biobeat. And the data was compared. We will get into this study later on in details, and I will show you all the insider data for this study within few minutes. Another thing that is important, Biobeat took the validation process not on simple patients, but on all the spectrum of patients, including the sexes, the BMIs, the skin colors, the skin tones. It was not only an FDA regulation, it was also the way to prove that. I will show you the data later on, so maybe I can comment later on, but I wanted to show you the equal usability and equal good results among all the spectrum of colors. Again, I showed you the three modalities that we can go, and I think that it's very simple to go and to try to convince you on both most important ways. So let's go for the Biobeat. And my journey with Biobeat started at Mayo Clinic, Rochester, where we got to perform the validation process of the Biobeat versus the arterial line. I think that this study is a milestone due to the number, the good methodology, and the statistics that we had. So let me deep dive into this study and give you a glimpse on what we did. We got 98 patients in total, but finally we got only 92 patients because some patients deteriorated during their stay in the ICC unit or the ICU unit after surgery. So eventually we got 92 patients from all skin tones, from 1 to 6, and I will show you specifically the data for each skin tone later on. Patients underwent a heart surgery, and we used that period. We got that opportunity where they had intra-arterial monitoring to monitor those patients in parallel with Biobeat system, as you can see here in the sketch, and in the monitoring system. I can tell you that we had 96 patients. The mean age was 63. There were 33% of female, all skin tones, more than 1,300 hours, more than 3.5 million measurements. And you can see here that we got huge and tremendous data to show. First of all, what is nice about the heart surgery, that usually it is our real life population. It is the real life population in terms of smoking, age, obesity, diabetes, congestive heart failure, hypertension, ischemic heart disease, and even valvular disease because of the nature of the patient population. And this gives me, as an invasive cardiologist, a huge assurance to make sure that Biobeat was proven and validated on real and good population, a real population of sick patients, not only healthy patients. Another important thing is that patients were on medications, usually on heart surgeries, especially the medications related to blood pressure. We do not stop them because we don't want the blood pressure to get uncontrolled during or after the surgery. So there was beta blockers for 50% of patients. There was ACE or ARBs for 31% of patients. Calcium channel blockers over 20, diuretics and ischemic heart disease. I think I would remove it from here. Okay, so here we can see that we have on meds population and a real life population, which is important, very important for me as a physician. Let me show you here all data point by point, 80,000 points in each graph, which correlate the reference systolic blood pressure and the cuffless systolic blood pressure, meaning Biobeat versus the arterial line. And you can see the correlation, which is amazing. You can also see the correlation for the diastolic blood pressure. And you can see the correlation even for heart rate, which is something for me as a cardiologist. I mean, how can I ignore being a cardiologist or treating the cardiovascular system and taking considerations only on blood pressure and disregarding the heart rate? So for me, the assurance that the heart rate is as good as the blood pressure was amazing. But another thing I have to mention, usually in our daily life or medical practice, we do not take decisions according to single or to one measure. We usually make the decisions over the day average or the 24 average as appears in the guidelines, which is good. I think it's good. But for us in Biobeat, it's even fantastic because when we go to the averages, we see that the bias here in the averages is totally amazing. It's 0.3, which means that whenever we rely on averages, we have tremendous confidence that our result, our average, our mean is true. And let me show you what I promised about the skin tones. For the 96 patients, there is kind of an FDA regulation or FDA request to make at least 10% of each skin tone. We know that it's very sensitive to go and ask patients for skin tone directly. So we know that there is a way to quantify the skin tone. This method is, I can tell you, approved and very accepted in those studies. And it's called Fitzpatrick scale. Each patient will get a number in the Fitzpatrick scale from 1 to 6. And we can see that among all population, and specifically among each Fitzpatrick scale, we got a tremendous correlation. We are very happy with this correlation for the blood pressure, for the systolic and the diastolic. This gives us the confidence to say that Biobeat is as or equally accurate in all skin tones, which is a huge advancement for us in the North American medical practice and maybe in the entire world. Okay, now you will get the opportunity to see the inside of the study. I could choose all patients, and if somebody would ask, the supplemental data here that I'm showing is appearing on the entire manuscript, and you can just download it. But I got additional things here to show. We have always kind of a concern regarding to the night ABPM. I think that this concern arises from the classic ABPM where patients just take it out. We know that in order to consider an ABPM measurement as a valid one, There should be 25 measurements at the day and 12 at the night. And many patients do not get to the 12 measurements at the night. But here at Biobeat, we will get to around 35 or 40, depends the patient's sleep time. But if we take any patient and we consider sleep time or bedtime at 10 p.m., so we can see that also when we track the blood pressure, the systolic and the systolic from the reference and from Biobeat, and the diastolic from the reference from Biobeat. Again, I can tell you that this patient or this data is from arterial line. We see a very nice tracking. It's not perfect, but it's perfectly good in our terms of medical practice. Because if I will just track the two hands, I'll get some difference. But for me as an invasive cardiologist, I can tell you that this data looks amazing. For us, we have 830 measures at the day and 475 measures at the night. Total measurement 1,300, which is amazing. And we can see that the patient has atrial fibrillation. We know the hurdle or the difficulty of assessing blood pressure for atrial fibrillation patients because the other methods, the classical methods, rely on Korotkov sounds, and Korotkov sounds will sound different and will disappear sometimes according to the ventricular premature beat or to the atrial fibrillation or the tachycardia or the bradycardia. And we see that even for atrial fibrillation population, which are the feared population whenever we consider the blood pressure diagnosis, we can see that Biobeat performed in a superb way. And again, this is a real patient, statins, antiplatelets, insulin, calcium channel blockers, and so and so. I don't want to go over all the patients, but I chose some patients to show you the variability and the trackability and the day and the night periods of the tracking. I wanted to show you how many measures and how confident we are when we say that the device is accurate. And again, all those data are available online in the Journal of Human Hypertension, which belongs to Nature journal. I don't want to make it any longer. If you have any questions, I would love to answer them after I finish my presentation. And so please have them in the chat. Okay. But again, as you said, our real world, our real patients, we want to see the comparison, not with arterial line. The arterial line is a comparison for me to set my mind and tell myself and my colleagues that we have accurate measures. But for the practicality, I will go back to the research that I promised I will, and I will show you what we have. This study was published in the Journal of American Hypertension or American Journal of Hypertension, and you can see the data online. But let me take you and show you the thing that I said about averages. I told you that we don't make, when we take ABPM, we usually want to see the average of the day, the average of the night, and the average of the total measurements. So look how the data is closed. The data is closed in a way that is amazing. What does that mean? This means that we're just tracking it correctly. The simple mission is accomplished. Let me show you few patients. We can see here the patients, and I think that you are familiar now with the way that I presented the data for you. You can see here the Biobeat systolic and diastolic, and the cuff systolic and diastolic. And you can see here the entire measurements of the 24 hours. I think that the trackability is so perfect. But guys, what happened here at 7 p.m.? Something happened here. But for you as blood pressure specialists, as physicians, do you think that the inconsistency arises from Biobeat or from a problem in the ABPM that is exaggerated measure is being read here? Another thing, you can see the density, the number of the measures, and consider here that we have 97 measurements for Biobeat. So even if one measurement was off, it's less than 1%. affecting the average. So we are very confident. And I think that this is what we like in the ABPM in general. This is another patient here that you can see. And also you can see the night average or the night period. Another patient. And I'll just go over and show you the entire patients here. This is another accident, but I think the accident happened to the ABPM, to the cuff, rather than the Biobeat, because if you see the entire day, something happened here just before 10 p.m. I don't know what. Another patient and another patient, another accident also that happened for the ABPM. And I could give you the entire number of patients, and you can find the entire set of patients online. I think that I convinced you in a way that we don't have a concern on accuracy and level of acceptance of the numbers and of the averages. But let me try to get the easiest mission for me. It's the mission that I will give you to decide. I think that we cannot compare the satisfaction, the workflow, the way that patients perceive the ABPM monitoring mission or hurdle versus the Biobeat. I think that each patient and each physician that tried or recommended Biobeat will know how to answer this by himself. I don't need to make any further. And you can go online and see here the publications that has been published. And I think that the new era will have more and more, not only satisfaction and compliance, it will give us also some data on the efficacy of treating blood pressure whenever we are using the big and the good modalities that give us the control and the understanding of the diurnal blood pressure, the circadian blood pressure, and not only the blood pressure, but also the other measurable parameters that I'm sure and I'm confident that during the new era of the blood pressure monitoring will be available more and more. I don't want to make it any further. I just want to check your chat. So maybe I will handle that to Jay, and you can also tell us about Biobeat process.
Dr. Hellou, thank you so much. Really enjoyed that fantastic overview of the evidence available. So I really appreciate you reviewing that with us. Yes, just wanted to talk about the patient is indicated for a 24-hour blood pressure. It's very simple. That patient is going to be in the clinic. They're going to be indicated for that 24-hour blood pressure. At that time, they can get a chest patch from the nurse from the clinic to be able to wear for the 24 hours. The beauty of it is after that 24 hours, they can peel that off and actually throw it in the trash or recycling. But when that test is done, you're going to have, as a clinician, you're going to have a very comprehensive report in a web-based portal that you can access anywhere. Next slide. This is an example. The nice thing is you have again, comprehensive blood pressure report that's interactive. You get to see the trends for the full 24 hours, but also the maximum, the minimums, the daytime averages versus the nighttime averages. You get to see those trends, to see that nighttime dipping or the lack thereof for some of these patients, but also that morning surge. The other thing that you're going to find with our new software, and you're going to see a little bit of an example of that here today, but is a digital diary that is also in a patient app that is also allows the patient to indicate when they took their medication. And then you'll be able to see in the report the timestamp, but also see what the effects were, but also the meals that they took, the activity that they had, if they exercised during the day, even meals, to be able to see both not just medication, but also lifestyle in terms of how that affects their blood pressure. This is a great example of utilizing Biobeat, as Dr. Hellou had mentioned, in terms of management. We see a lot of our customers actually utilizing Biobeat pre-treatment change and also following up post-treatment to understand what the effects were. So allows them to understand, if it's a change in their hypertension medication to see what the effects were. We do believe that Cuffless is kind of the future of a management and monitoring of blood pressure. It makes this very scalable. It is not limited by the number of cuff-based devices that you have and having to process those back in, but it allows you to actually, provide this to more and more patients. It is single use. It is disposable after use, but they can, have basically set it and forget it. Captures real world phenotypes too, along with enables that precise personalized therapy. Next slide. The nice thing about ABPMs and 24-hour blood pressure, there is existing CPT codes. The reimbursement has been in place for many years. They've had a national coverage decision since 2001. And if you want to have more discussions, we're happy to talk about that as well. Next slide. And now we'll open up to the Q&A.
I see here so many questions, and we thank you for that. Maybe I will handle some questions to Jay as they are more, let's say, device specific. With a 24-hour patch, can we have them wear this longer than 24 hours so we can gather more data? Maybe there is a situation that happens part way into this time frame which warrants a longer use time frame. Technically, this question is for Jay, so I will hand it for you.
Yeah, so then that is a great question. Obviously, I think we all believe more data is more valuable, but I will say there's two things that really dictate that this is a 24-hour test. One is the CMS reimbursement. It is very specific for a 24-hour test. If we would submit a 25-hour test, it would be denied by CMS. So the reimbursement is really the big piece. But when you actually look at the ACC/AHA hypertension guidelines, they actually list the 24-hour blood pressure, and specifically the 24 hours is a class 1A recommendation for these patients. So again, both guidelines and CMS both dictate that 24 hours.
I will have a question that is for me regarding to the validation study. Has it already been published? It's ready, and it will become public for patients and for doctors during the American Heart Association conference on November. It's ready. It's finalized. The PDF is ready. I don't have the DOI yet, but I promise that we can do our best. Sharon, maybe you can help us, or Jay, in order to forward this study for people who would love to, for the panel, for the people that joined this conversation, or people who would just write their emails in the chat.
No, definitely we will share once it is published. We will share it with our mailing list, and obviously anyone who joined this event. We have some more questions.
I will pick one question from Dr. Ali. Yeah. What are the limitations on placement for the device? Okay, so the device should be placed on a shaved skin. The device should have direct touch. Actually, I can tell you that you are all familiar with the technology or with the thing that is happening. It's so similar to the smartwatch detector or sensor, but it's much more complicated and much more accurate for analysis of real patients' data. So before putting the device on the chest, there should be simple 10 centimeters or 10 centimeters or 3" over 3" shaving of that area when needed. And then the device should be placed on that area. The device would be turned on and then connected to the mobile app for the patient for the 24 hours. And it will transmit the data directly to the cloud, and it will get back to us as physicians and as people who take care of the patients after the patient will finish his monitoring time. I should also tell you that the patient should not shower during the 24 hours, cannot swim, cannot do any water activities. And we recommend patients to do their daily activities, but not exercise activities due to the sweating and the movement of the device.
No, that's very
The
good.
cost of the device, I don't know if you want to comment on that, but I don't know if it's general or it's per site or per. You can take it.
Yeah, so yeah, our standard cost is $120 per test, and it is the nice thing about it, it's all in. There isn't an additional access fee for the data. There isn't an access fee for the portal, so it's all in on that cost. And then I also see the next question: are there plans for pediatric patients in the future? You know, as of right now, this is for 18 and up. All the testing and validation study has been on adults. We may have plans to go after pediatric indication, but that is potentially in the works for the future. Is it covered by insurance?
Yes. It's in the research pipeline. It's very interesting also for me. I'm sure that this patient came from the real life, because we can see that it's even a bigger problem and more difficult to get the ABPM for a child rather than a mature man. And I know the appeal. And before Biobeat can say that we have a device that can be used on pediatric patients, it should be validated. And I tell you that the thorough process of validation for below 18 is even more precise and even more difficult. And I think that this will be in the pipeline.
Yes. Is it covered by insurance? Yes, it is well covered by insurance, including CMS. A lot to do with the national coverage decision it's had so long, since 2001. Epic integration. We do have Epic integration. We are certified Epic. We have an app in the Epic App Store and an API that can be utilized. Try to find some more questions for you, Dr. Hellou.
Yes, I like it. There is a question from Sarah. Examples, what frequency was the data being pulled from the patient? Every second, every minute, or other? Okay, I can talk in two different ways. One way is talking about the ABPM protocol or the ABPM application that is also validated as ABPM and is FDA cleared for ABPM monitoring. In this specific application, we do pull the data every 15 minutes. We can pull the data more frequently, but for this purpose, we can pull the data every 15 minutes. And in that way, we have 97 points, 97 measurements. The 97 measurements come from 24 hours times 4, and then one another measurement in order to complete the circle. For us, it's more than enough. For the patient means and patient needs, he doesn't feel anything. The device decides whenever the correct time to measure in terms of good signal and good quality and stability of the signal. And this makes the data more and more accurate. There is a capability of the device in research mode or in other applications to sample the data every 5 seconds. But there is nothing to compare at each 5 seconds. I can also tell you something from the vision of the physicians, not yet the company. The device is capable of recording a ECG, and I hope, it's just a hope, that this device can give us and give me as a cardiologist also an insight over the ECG of the patient, the rate and the rhythm, which is very important for me in decision-making and in the most practical way of the medication that I have to prescribe. So I see that there is kind of a tension between the will and the dream of the physicians and the vision of the physicians, me as you, as all the audience here, that I can see what I need. And I want more and more applications, and the responsibility of Biobeat of giving the accurate and the good data and good results that can be a rock that we can base and we can take into considerations whenever we take clinical decisions. Another thing that I have to mention, for me as a physician, when I get a patient and let's say I diagnose blood pressure or hypertension for that patient, according to Biobeat. Actually, for me, I have to give a trial for that patient and to give him some medications. Usually, I'm not good at that, or I cannot guarantee that I'm good at that. So the guidelines also ask me to make sure that I achieve the target. And once we are talking about achieving the target or being confident that we choose the correct treatment for a patient, I think, and one of the studies that is in the pipeline, it's on my desktop, actually, I'm lazy. So this study says that we should try to use Biobeat to compare or to assess the advancement or for achieving the blood pressure goals. And I think that whenever you see the clear data and the clear picture of the baseline, it's very easy to make decisions and to see the changes. So along with Dr. Maria Delgado, which does a huge and great job in the American Heart and also in her clinic in UHealth in Florida, I think that we are trying to show the usability and the good effect of seeing the patient from the Biobeat eyes and to do the decisions in a very wise manner. So let's consider it. I think that it's a good way to try to understand how we can take over our control of patients with Biobeat. I will take a look for another questions. I see a new one.
Yeah, I'll as you're looking, the patch does require calibration. So at the time of placement, we do calibrate with a standard cuff. That we follow the FDA recommendations of the AHA and ACC recommendations of 3 measurements, 1 minute apart after the patient has rested for a minimum of 5 minutes to get a very accurate baseline.
I see here very important questions. Maybe for my next presentations, I should take those questions and answer them because I see it's very valuable. First of all, regarding to the blood pressure values, we are not here to set the blood pressure values. I think that this is a usability or a device to measure the blood pressure accurately. And then the values, I will keep it for the American Heart and for the European Heart to decide and set the values and set the targets. So for me, for men and women and all the targets, we don't do that. I can just tell you that Biobeat is as accurate in assessing the men versus the women blood pressure, which is very important, and you can see it in our publications. Regarding to the Biobeat plot on heart rate variability, HRV, I think that this is what you mean, Joe. I think that, again, this is the tension between the company, and whenever you use the ABPM monitoring for the patient, despite the fact that this data is collected, it will not be presented to the physicians. But for research purposes, yes, I can tell you that I can see some of those data. And this data is available, but not for the clinical use. You know why? Because there are no guidelines on how to take that over and how to try to understand how to do or how to manage those variabilities. Yes, Muriel, the data or the accuracy is also kept for pacemaker patients. Even we got it for paced beats versus non-paced beats. So for me, I'm very confident that the device is accurate in normal sinus rhythm, in atrial fibrillation, and in pacemakers as well, which is very nice for me. Does a person with high daytime blood pressure and normal nighttime blood pressure is classified as... Okay, great. Wow, Antonio had a great question. One of the things that I mentioned in the presentation said that the night blood pressure is more important than the day. It's a statement. I don't want to argue on that statement, but there are some people who said that, and here I give you that slide. There is a big entity called dipping state and non-dipping state, also on my desktop. I promise you that you will see those publications very soon. But Biobeat can accurately assess the night period. And we can also get some extra measures, as you got clues here from HRV and some other things. I'll keep it to the publication. But we can see and understand what happens at night for patients versus healthy people. And we can see the dipping state. So Biobeat report numerically, yes, will and does provide dipping state or dipping change, which is the change from, or the percentage of the change from the day and the night. In the report, it does that for systolic alone, for diastolic alone, and I think also for mean blood pressure. If I'm wrong, correct me, Jay. And you can see that in the report. The report is very comprehensive. And usually whenever you have the opportunity to be the referring physician for that, you can also access that report on the portal, and you can see the report, and the report is kind of interactive, which is very important. I think that you do practice hypertension in the real world, because this is something that really interested me whenever I had the first look on that. And I was amazed and positively satisfied. Any more questions? If I missed something important, you can poke it up.
Yeah, the one right above Antonio, from the one from Andrew Park in terms of Biobeat reading with extreme BP readings above 180 or below 110.
I can't see that.
It's by Andrew.
Okay, how did the Biobeat device perform in extreme blood pressure readings? For example, in the analysis of the ICU data, how is the R2 for reading below systolic 110 or greater than 180? If you're talking about the ICCU data, this is kind of one patient that I randomly collected here. And you can see that some measurements are below 110. Less measurements are above 180 in our setting. I think that you can see it here, right? And usually in the ICCU patients, we try to avoid that. And if that happens in the ICCU, sometimes it's something that we should further investigate, because we can just control the blood pressure. But you can assess here, and you can maybe see that it's satisfying what we can see here in the data.
Yeah, and we look at the specifications for the device itself. The effective range for the systolic is 60 to 250, and the diastolic 40 to 150. So we do have the capability of managing, or at least monitoring, even in those higher and lower readings. Then there's a question on tattoos, and so specifically, if there is a chest tattoo right where you're going to want to place the device, we do not recommend, and it is contraindicated to place it over a chest tattoo. So I would go to the contralateral side to if they have a tattoo-free spot on the other side. Certainly, you can place it there. Otherwise, if they have a full chest tattoo where their front is covered, that patient may not be an candidate for the Biobeat device. Does the prescribing doctor have permission to include commentaries in the Biobeat report? So that's actually a fantastic question. So there's two things. So you do have the capability of inputting comments and part of the diagnosis and notes within the report, but also with the recent update that we had that included the digital diary, but also within that is the various different diagnoses that you can click on, and it'll actually pre-populate some of the definitions for those diagnoses that you can go in and edit if needed, but it does pre-populate the language that would follow those diagnoses.
I just want to mention that questions that we cannot answer now, we will get back to you and contact you directly with answers and the ability to actually jump on a Zoom call with us to make sure that no question is left unanswered.
No, perfect. Now, thank you everyone very much. it was our honor to have you join us for this presentation, and we look forward to the next opportunity. Dr. Hellou, thank you so much.
Thank you for the invitation, and thanks everyone for the challenging questions. They are really valuable.
Very good. Thank you.
Very good. Thank you very much, everyone. We will share the recording and also ways to contact us. And we wish you a great rest of the day. And thank you again for joining us. Goodbye.
Thank you. Bye-bye.